Good. Well, thank you very much for the invitation. And it's good to see quite a few people here, more each year, which must be a good sign. So, the thing about guidelines must be that if you apply them, you get some kind of result. And of course, that is exceedingly difficult in matters of male infertility. There is evidence, however, for IVF and ICSI. There is evidence for hypogonadotrophic hypogonadism, in which using gonadotrophins usually stimulates spermatogenesis. But with the exception of those two, one intervention and one treatment, we cannot relate any treatments that might derive from the guidelines to an outcome. This makes the whole issue exceedingly difficult, particularly in a unified or almost unified national health service, where socialized medicine has an awful lot of connotations, both political and financial. So, as was famously once remarked, when you're trying to solve a problem, follow the money. The money is with IVF treatments. This is the currency of so-called fertility treatments, of course, in fact, really rather confused with fertility solutions. For the IVF ICSI procedure doesn't provide any treatment whatsoever for the man. And the guidelines that exist for UK practice have come from the College of Gynecologists, and these actually are about preparation for assisted reproductive technology. They are not really about investigation. They're investigative tests, yes, but they are not aimed at any treatment, but rather for being able to provide what is thought to be the solution. Now, the second enormous problem is that a guideline does exist for treating infertile couples, and it exists for couples, not individuals. And this actually is why those men who arguably should be seeing urologists, who should have a treatment guideline applied to them, are nowhere near a urologist, because of course the currency for their treatment lies exclusively with the gynecologist. This is not their fault. It's the way it has happened with good intentions in a nationalized, socialized medical system. I'm not going to read this out, but this is what happens. This is what happens in fertility units up and down the country. So that, I'm afraid, is the way the interview goes. Note that the male patient, as we all know, is never examined by a gynecologist. Rarely, there are a few who do, but mostly not. And certainly not investigated for those important aspects that relate to male health, and particularly the development of the metabolic syndrome. The other interesting philosophical point here is that the poor, desperate couple who will do almost anything to achieve a pregnancy and a baby, are impressed by the success of IVF and ICSI. But if you stand back from this and you look at an intervention which succeeds at best in 35% per cycle, at best, and nationally less, and you say, so does this intervention work? Apply it to any other intervention. The answer is not yes, it's no. So we're really behaving in a slightly aberrant way as doctors before we even begin. So the interview continues. And that is a very, very cogent point. Because in order to justify this intervention, then clearly the answer to that question has to be this. So it may well happen that attempts at natural intercourse fail. They cease. So we're out of the loop before anything has ever been done. And then there's usually a gap whilst these people are treated. And depending upon where they are, they will have a variable number of treatments, depending upon their resources and the resources of the local health economy. So this is the male patient. At the end of the road. So, we need to try to change this. We can only change it, of course, if we get to the patients. And I would suggest we can only change it if we begin to understand the basic investigation, which is semen analysis. I'm not sure whether you can see this, but this was the same patient, different places, both reputable places, a reputable fertility unit on the left, a reputable diagnostic lab on the right. Of course, what had happened here was that the poor man had refrained from ejaculation on the left-hand side of the slide here for 4 weeks, and then the first bit of the ejaculate had been missed. And so in the same week we have this wide variation, a very simple explanation, but huge variations between laboratories, between observers, and within individuals. And so we need to understand the qualitative values of the basic investigative tool for urology. And of course, the vast majority of semen analyses are being done in fertility units. In our local trusts, the vast majority of semen analyses are done to determine whether or not vasectomy has succeeded, or as a pretty basic diagnostic investigation. Now, some of the variations have been admitted by ourselves. On the left side there are the 4 iterations of the WHO parameters defined mostly by committee, and then on the right the currently used standards, which completely differently were derived from 1,700 couples whose fertility was proven in 1 year. Now, if you look at the red columns, then those can either be used to tell a patient that actually, with these numbers, fertility is possible, or, of course, they can be used conversely to justify IVF. So we have to be very careful with these numbers and try and understand them. Now, you need a very long memory or to be terribly ancient to remember what happened before ICSI. ICSI has been, or was at the time, a revolutionary treatment for male fertility, 1992, 1993. So there's not much information before that. The Canadian study on the left-hand side of the screen was published in 1983 and shows what happens in the untreated state. And you'll see that sperm densities of around about 9 million were associated with a 20% cumulative pregnancy rate over the next 36 months. Now, I say this merely to indicate that possibly the results from IVF-ICSI are not quite so, in inverted commas, good as they might be, as there is an underlying natural conception rate, which was reiterated in the Walcheren study of 1997, only 3 or 4 years after ICSI started. So, these are the RCOG guidelines, and this really is what is happening, if we are honest, to the male patients whom we may or may not see who yet have been to a fertility unit, because NICE says that couples must be seen together. So this is what's happening. And it's quite a lot of nothing, as you will see. They pick out the hypogonadotrophic hypogonads, and they go to an endocrinologist. Karyotype, it's recommended, they have normal karyotype, well that's okay. That goes for counselling, and it is admitted that many of those, of course, will be Klinefelters and they'll need testosterone replacement. CFTR positivity implies to the gynecologist's absence of the VAS. Well, of course, having not examined them, then it may well imply that, but it may well not. Interestingly, the guideline does give us urologists a little chink of opportunity there. There is no mention at all of physical examination. Compare this with the European guidelines, which have been regularly updated, and there are extremely important and cogent points here. I needn't read them out, but a diagnosis being mandatory is clearly very important, and from the foregoing it is quite evident that such a diagnosis will never be possible on the basis of the current Royal College of Gynecologists guidelines. The Y microdeletion is interesting in the light of Sucks's very interesting work later to be revealed in one of the poster sessions. I think Sucks and his group found that Y microdeletion was a very rare event and was suggesting a lower sperm density as a threshold. I must say that's my own anecdotal observation. But these guidelines are good. They're great. They're fine. They've been modified frequently, updated, make sense, and are clearly the right thing to do. So in summary, we need to get into those fertility units. I don't think we'll change the NICE guidelines for the College of Gynecologists. This is not wickedness, but treatment, that is a solution, is in the hands of the gynecologist whilst the infertile couple need to be seen together. Because we certainly can't do what the gynecologists do, but they, through their guidelines, imply that they can do what we can do, which clearly isn't right. So we need to get into those units. We need to be nice, helpful. We need to understand the meaning of a diagnostic semen analysis and not merely to follow the lead from laboratories which are principally concerned with endocrinology, with embryology. Thank you very much.
Are there any questions? We have time for one or two short questions from the audience, please. Microphone 2.
Thank you very much, Jonathan. There is a little bit of change because the NICE quality standards have said that all men should be assessed. They don't stipulate whether by a gynecologist or a urologist. But we are in a little bit of difficulty because you can only make the quality standard based on the NICE guidelines to begin with. So if something's not in the NICE guideline, you can't just incorporate it. So we're stuck in a bit of a corner. If we don't, get involved with the NICE guidelines, you can't then do anything later on. So there's a little bit of a change. But again, I agree, probably not enough.
Yeah, but I think I totally agree, Asif, thank you. That's a very useful change, because if we can get into those fertility units, and this is the key, then most of our colleagues, gynecologists, as we know, they're not really, they didn't sign up for examining the scrotum. And to have us next door saying, don't worry about that, we'll do it, I think we can begin to change it from within.
Are there private fertility units in the country? And if so, is there a different organization in the private sector?
No. No, it's a very interesting question. Do some private units involve urologists more? Yes, they do. Some. But some resolutely do not. Because, of course, to be cynical about it, all we can do is to delay the time at which the treatment can commence. And we wouldn't want to imply that somebody could make the bloke more fertile. I mean, this would be a great, great error. Might have to buy a motor car with a shorter bonnet.
Thank you, Jonathan.
Thank you very much.